We perform our sensory testing by going out into the periphery of the body and using various instruments such as our Semmes-Weinstein monofilaments, or a pinwheel, or a tuning fork, or some cold or hot substances. And what we do is we go out and we go into the periphery of the body, and we stimulate various populations of sensory receptors that are located out in the periphery of the body. We'll talk about these various different types of sensory receptors. Now, these sensory receptors can be classified in three basic categories. The first category that we use to classify sensory receptors is based on the type of stimulus that these sensory receptors detect. And we say detect, we mean that in the presence of this certain type of stimulus, these sensory receptors will fire, meaning that they will depolarize and generate an action potential. So we classify sensory receptors based upon the type of stimulus that they detect. So for example, there are sensory receptors that respond in the form of generating action potentials to tissue deformation. They respond to tissue deformation, and we refer to these sensory receptors as mechanoreceptors. We have other populations of sensory receptors that do not respond to tissue deformation. However, they respond to changes in temperature, and we call these thermoreceptors, meaning that when these receptors are exposed to hot or even cold, they will respond by firing an action potential, meaning that there's a depolarization of the neuronal cell membrane and the generation of an action potential down the axon of that neuron. And that's what happens when you step in the shower and the water is cold. You think the water is cold because that water comes down, hits your skin, and activates some of these thermoreceptors that fire when they're exposed to water that is substantially below body temperature. In other words, it's substantially cold water. You interpret that in your brain as, wow, I'm in cold water. And that the reason you get that interpretation is because of the firing of various thermoreceptors. There are other populations of receptors that respond to photons. In other words, that respond to light. Now, where would those receptors be located? Probably located in the retina of the eye, correct? Other sensory receptors respond to chemical changes or respond to the presence of chemicals. Imagine a good example of those would be found in the olfactory epithelium, way up in the nasal cavities. In fact, the sense of smell is simply a response to aerosolized chemicals that you breathe in into your nasal cavities. And then finally, there are other populations of sensory receptors that respond to tissue damage, or they respond to stimuli that has the potential to cause tissue damage, and we refer to these as the nociceptors. These are the special sensory receptors that are typically responsible for giving us our sensation of pain. So that's our first classification of the different types of sensory receptors, is based upon the type of stimulus that they detect. Another classification system of sensory receptors is based upon their location in the body, or the location of the activating stimulus that results in the generation of an action potential in these sensory receptors. And there's three basic locations where sensory receptors can be found. The first location are areas located within the body, within the substance of the body. Generally, these are found in and around blood vessels and in and around the viscera. And these are the so-called interoreceptors that respond to stimuli within the body. Now, the interesting thing about interoreceptors is that generally this sensory stimuli from blood vessels and from the viscera of the body is generally unconscious. It does not reach consciousness. However, is responsible for different type of reflex control of various viscera and the blood vessels. So that is the interoreceptors. And if we have sensory receptors located within the body, then we probably also have sensory receptors located outside the body or near the body surface. And these are the so-called exteroreceptors. And these are found generally near the body surface or even on the surface of the body, and they generally respond to stimuli located outside the body. So, for example, these receptors are responsible for giving us our sense of touch, our sense of pressure, our sense of temperature, pain, vision, hearing, equilibrium, taste, and smell. And then finally, we have a population of receptors known as the proprioceptors. Okay, so we had the interoreceptors, the exteroreceptors, and now we have the proprioceptors. And what proprioceptors do is they respond to the degree of stretch of the organs that they occupy. They respond to the degree of stretch of the organs that they occupy. And so, okay, what kind of organs, where do we find proprioceptors? What kind of organs do they occupy? Well, proprioceptors are found in skeletal muscles, and they respond to the degree of stretch of skeletal muscles. They're found in tendons, they're found in joints, they're found in ligaments, and they're also found in connective tissue coverings of muscles and bones. And it's the job of the proprioceptors to constantly advise the brain of body movements and body positions in space. And we'll talk about at least two different types of proprioceptors here as we go. So that was our second classification of sensory receptors. The first was classifying receptors by the type of stimulus that they detect. Number two is the location in the body where these sensory receptors are found. And our third classification of sensory receptors has to deal with the structural complexity of those receptors, and we find that there's basically those receptors that we could call very simple, and those receptors that we could describe as being very complex. And we're going to spend most of our time in the remainder of this program on the simple sensory receptors. And simple sensory receptors are found throughout the body and monitor most types of general sensory information such as touch, pain, pressure, vibration, hot, cold, itch or tickle, and all that stuff. And we'll talk mostly about those as we go along here. But there are also complex sensory receptors that are much more structurally involved and are actually our sense organs, meaning that they consist of multiple different types of cells. Now, these are generally consist of localized collections of cells associated with the special senses of sight, smell, taste, hearing, and equilibrium. And we talked a little bit about some of those in dealing with the cranial nerves. But for the remainder of this program, let's focus our attention on the so-called simple sensory receptors. Now, within this classification of simple sensory receptors, there's two basic subtypes that we'll be dealing with. The first are the ones that are exceedingly simple, meaning that they have receptor endings that are unencapsulated, consisting of free nerve endings, modified free nerve endings, and or hair follicle receptors. And then we have slightly more complex simple sensory receptors that have modified receptive endings that are encapsulated in either fibrous tissue or membranes. And there are several different types of encapsulated receptors, including Meissner's corpuscles, Ruffini corpuscles, Pacinian corpuscles, Krauss end bulbs, Golgi tendon organs, and muscle spindles. And we're going to go over some specific exam procedures designed to stimulate each of these special populations of both unencapsulated and encapsulated sensory receptors. So let's talk about these a little bit. If we consider the unencapsulated simple sensory receptors, the most basic type that we see is what is known as the free nerve endings. Now, free nerve endings are located widespread throughout the body. They're located both within the body, they're located on the exterior surface of the body, and are also located within most dense connective tissues such as ligaments and tendons and joint capsules, and so therefore they qualify also as sensory receptors. Now, free nerve endings respond to various different types of sensory information, including temperature, including chemicals, including pressure, including pain, and so therefore these free nerve endings qualify as thermoreceptors, as chemoreceptors, as mechanoreceptors, and also as nociceptors. And it's interesting, within the stimulus classification of nociceptors, these free nerve endings respond to a variety of noxious stimulus, including pain, and pain is generally associated with tissue damage. They respond to hot, they respond to cold, they respond to pinch, which is a form of pressure, and they also respond to chemicals. And chemicals qualifies them as chemoreceptors, and you may or may not know this, but it's the release of chemicals and chemical stimulation of free nerve endings that is responsible for our sensation of itch and for our reflexive behavior that compels us to scratch an itch is due to chemical irritation of free nerve endings. So free nerve endings are found in most body tissues. They're most densely located in the connective tissues such as ligaments, tendons, in the dermis below the epidermis, in joint capsules around synovial joints, and also in the periosteum of bone. And it's the free nerve endings that are responsible for giving us the so-called periosteal reaction. They're also located in the epithelia, such as in the epidermis, on the cornea of the eye, in most of the mucosa, and also surrounding epithelial glands. In addition to free nerve endings, we have modified free nerve endings, the most abundant of which is the Merkel's tactile discs. And Merkel's tactile discs are located and pick up sensory information on the exterior of the body, and mostly responsible for our sensation of light touch. So that qualifies the Merkel tactile discs anyway as exteroreceptors and also as mechanoreceptors, meaning that they respond to light, very light pressure. And so it's the Merkel's tactile disc, which is sort of a modified free nerve ending, that is responsible for the sensation you get when a fly is on your skin. And that fly only weighs nanograms, I guess. And however, those nanograms are sufficient to slightly deform the overlying epidermis, which causes a discharge or an action potential to be generated in these tactile discs. And these are found in the basal layer of the epidermis of the skin. And if we go all the way back to your study of the integumentary system, you'll remember that there's at least 5 layers of the epidermis. The most outer layer of the epidermis is the stratum corneum, the so-called corny layer. And the stratum corneum is the layer of the epidermis that we're constantly sloughing off as dead, keratinized epidermal cells. Below the stratum corneum we have the stratum lucidum, then we have the stratum granulosum, then we have the stratum spinosum, and then below all those we have the basal layer, also known as the stratum basale, or some textbooks refer to it as the stratum germinativum, which is suggestive that this is the germinating layer. And it is the stratum basale, or the basal layer, that's the germinating layer of the epidermis of the skin, meaning it's this layer of skin that is mitotically active and constantly replenishing those dead and sloughing off stratum corneum cells. So it's amongst these cells in the basal layer of the skin that we see these modified free nerve endings known as Merkel discs. And to my knowledge, these are the most superficial of all of the sensory receptors. In fact, to my knowledge, this is the only sensory receptor that penetrates into the epidermis. All other sensory receptors that I'm aware of are found in layers deeper than the basal layer of the epidermis, which we'll talk about here as we go. And then finally, our third type of unencapsulated sensory receptor would be a hair follicle receptor. And these are simple sensory receptors that are found in and around surrounding hair follicles. These are responsible for picking up stimuli on the exterior surface of the body, where the hair follicles project out of the epidermis. And they are mechanoreceptors, meaning that they fire action potentials when the hair follicle that they surround is deflected. And this is important information because you can test the hair follicle receptors with your Semmes-Weinstein monofilaments simply by dragging your monofilament and deflecting hair follicles. So there's a couple of different ways to use your monofilaments and a couple of different ways to test sensory receptivity in the periphery. One would be to stimulate the Merkel's tactile disc by direct pressure with your monofilament. Another would be to use your monofilament to deflect hair follicle receptors. So this is important information for our sensory examination. Then when we consider the encapsulated types of simple sensory receptors, there's several different types, and we'll just go through this list very quickly. For those of you that have the handout materials, I've given you a chart with each of these different types of sensory receptors described. The first of which is the Meissner's corpuscles. These are exteromechanoreceptors. They respond to light pressure and discriminative touch, And by discriminative touch, we mean that when a Meissner's corpuscle is stimulated, the brain can very accurately localize the area on the body that's being stimulated. That's what we mean when we refer to discriminative touch. So one way to test the Meissner's corpuscles is to ask your examinee to close their eyes as you apply pressure with your Semmes-Weinstein monofilaments at various parts of their body and ask them to describe exactly where they feel the stimulus. The Meissner's corpuscles are located in the dermal papillae of hairless skin, particularly in the nipples. They're dense in the genitalia, in the fingertips, in the soles of the feet, and in the eyelids. And it's the Meissner's corpuscles that we test when we are testing for two-point discrimination on the fingertips. They're very densely located in the dermal papillae of the fingertips. And if you remember, the dermal papillae are those ridges right underneath the epidermis that give us our fingerprints. Pacinian corpuscles, also known as lamellated corpuscles, are exteroreceptors. They're interoreceptors, and they also function to some extent as proprioceptors because they are found in limited populations in tendons, ligaments, and some joint capsules. They're most abundant on the fingers, on the soles of the feet, on the external genitals, and the nipples. And these are mechanoreceptors which respond to deep pressure, stretch, and vibration. And in addition to being found in some of the connective tissues, they're mostly located in the dermis and the hypodermis. And if you remember from your study of the integumentary system, the dermis is immediately below the epidermis, and then the hypodermis is below the dermis. Sometimes the hypodermis is referred to as the subcutaneous tissue. Pacinian corpuscles also found in the periosteum of bone, and in limited populations also found distributed around the mesentery in the abdominal pelvic cavity. Ruffini endings are found deep in the dermis, in the subcutaneous tissue, and also in joint capsules. These are exteroreceptors and also proprioceptors because of their location in joint capsules. They're mechanoreceptors that respond to deep pressure and stretch. Muscle spindles are found in skeletal muscles, particularly in skeletal muscles of the extremities. They function as proprioceptors, constantly advising the brain of movements of muscles and positions of the limbs. They're mechanoreceptors, meaning that they respond to changes in muscle stretch and changes in muscle length. Golgi tendon organs are proprioceptors found in tendons of skeletal muscles. They function as mechanoreceptors, which means that they fire action potentials when they are mechanically deformed by tendon stretch and or tension building up in the tendon. And finally, we have our joint kinesthetic receptors, and these are our famous proprioceptors found in the joint capsules of synovial joints. And they function as mechanoreceptors and also as nociceptors. And for those of us that are chiropractors, it's the joint kinesthetic receptors that fire when a joint is taken beyond its normal range of motion, perhaps into the injury zone. These joint kinesthetic receptors will notify you with a painful sensation when there is damage or injury and joints are taken beyond their normal ranges of motion. And those of you that have the PowerPoint presentation, or if you don't have the PowerPoint presentation, simply refer to your course notes that accompany the program. I have a diagram here that shows two types of afferent neurons and two different types of receptive endings. The first simply is a pictorial diagram of free nerve endings, and the second is a pictorial representation of some type of an encapsulated nerve ending. And typically these encapsulated nerve endings are membranous, typically multi-layers of membrane that detect some sort of deformation, perhaps due to pressure, for example. Pressure could cause deformation of this encapsulated membranous ending, and that could spark a nerve impulses to be generated up this afferent neuron. Now, the afferent neurons that we're dealing with fall into a classification known as unipolar neurons. Now, typically when we think of neurons as having a cell body at one end, an axon coming off of the cell body, and then receptive endings known as dendrites at the distal end of the axon. Well, these sensory afferent fibers that we're dealing in the peripheral nervous system are of a classification of neuron known as the unipolar neuron, and have slightly different configuration. They have their nerve cell body, but the nerve cell body is located juxtaposed, or I should say interposed, between a peripheral process and a central process. And let me explain that. It's the peripheral process that projects from the nerve cell body out to the receptive endings. So with these afferent neurons, these afferent unipolar neurons, the nerve cell bodies are located in the dorsal root ganglion. And in the lower extremities, these dorsal root ganglion are located immediately prior to the exit of the nerve root from the corresponding spinal level. So these dorsal root ganglion are located immediately central to the exit foramen at L1, L2, L3, L4, L5, S1, S2, etc. And from there, the dorsal root ganglia and the nerve cell body sends a central process up the cauda equina to synapse in the dorsal horn of the spinal cord, or in some ascending pathway in the white matter of the lumbar or sacral spinal cord. And we're not going to discuss the ascending pathways of the lower extremity. Those, of course, would be the fasciculus gracilis and or one or the other of the spinal thalamic tracts. That's beyond the scope of this discussion, but suffice to say that the central processes project from the cell body and the dorsal root ganglion up into the spinal cord, and then also from the cell body and the dorsal root ganglion is sent out a peripheral process, which then goes out into the periphery of, say, the skin of the dorsum of the foot, for example. And so it's a slightly different configuration. And what we typically think of dendrites as the receptive endings, in this case of these sensory afferent neurons, those dendrites involve these specialized receptor endings, which could include either the free nerve endings or any of the other types of encapsulated specialized endings that we see. For those of you that have your handout materials, I have a cross-sectional diagram here that shows a section of skin and this is hairy skin versus non-hairy skin, known as glabrous skin. This is a section of hairy skin that shows both the epidermis, the dermis, and then deeper subcutaneous layers. And it demonstrates the variety of different types of specialized sensory receptors just in the skin layer. So, for example, in the center part of the diagram, in the dermal papillae, just underneath the stratified squamous epithelium of the epidermis, we see a Meissner's corpuscle, and you can see that that receptor is perfectly positioned to be able to detect very slight perturbations on the surface of the skin. Other sensory receptors, as you can see, are wrapped around the base of hair follicles. And what would be the function of those sensory receptors? Well, those sensory receptors detect deformation of the base of the hair follicle, and any kind of deformation of the hair follicle will cause an action potential to be produced in these specialized receptors, and that information then is conveyed up these afferent fibers up into the spinal cord. So clinically, you may want to include, as part of your sensory examination, you may want to include different procedures or maneuvers that involve deformation of the hair follicle. For example, you can take your monofilament and not only touch the skin, the surface of the skin, which would cause a receptor potential to be generated in the Meissner's corpuscle. You may also want to drag your monofilament along some of these hair follicles to create a deformation of the hair follicle, which would test a completely different class of sensory receptor. Also in this same diagram, a little bit deeper down at the junction between the dermis and the deeper subcutaneous layer, we see Pacinian corpuscles. We see also all different types of receptive endings at the junction of the epidermis and dermis. We see free nerve endings there, which are capable of detecting any kind of tissue damage or deformation of tissue, particularly damage to tissue would cause response to the free nerve endings. So the long and short of this is there's many different types of receptive endings that we test with our sensory examination. Those of you that have the handout materials, here also is another diagram which shows some of the connections of the proprioceptive receptive endings, the Golgi tendon organs and the muscle spindles. The Golgi tendon organs are located at the musculotendinous junction, and the muscle spindles are located deep within the belly of the skeletal muscles. They're found within the intrafusal muscle fibers, and both of those basically do the same thing. They send sensory information to the spinal cord about changes taking place in the muscle, and that's information that our central nervous system relies on to tell us about the position of our body parts in space. And we have different examination maneuvers which we'll get to test the Golgi tendon organs and also the muscle spindles. And the information that comes in from these receptors, these Golgi tendon organs and these muscle spindles, and also, as we talked about earlier, joint mechanoreceptors, those all contribute to our joint position sense, our awareness of our body, limbs in space. And I remember back when I was teaching anatomy and physiology at the community college, when we got to this section of the neurologic system, I always made a demonstration to demonstrate this to my students, and I would have one student come up to the front of the class, and I would ask them to close their eyes, and I would ask them to extend both of their arms out to their side with their wrist, elbows, and shoulders all in alignment with the shoulders at 90 degrees of abduction. And then, with their eyes closed, I would ask them to tell me the angle of their elbows as I move their elbows from 0 degrees of elbow flexion to 45 degrees of elbow flexion to 90 degrees of elbow flexion, and eventually to 115 degrees of elbow flexion. And what I would do is I would move the elbows, for example, into 90 degrees of flexion, and I would say, I would ask them, true or false, your elbows are now completely straight. And of course they would say false. And then I would straighten their elbows completely out, and I would say, true or false, your elbows are bent to 90 degrees. And they of course would say false. And then I would ask them, okay, as I put your elbows in this position, what's the approximate angle of your elbows? And they would say, well, it's approximately 45 degrees or approximately 90 degrees. And they answered correctly based on the choices that I gave them. They answered correctly, and they correctly were able to identify the position of their elbows every time, even without looking at their elbows. And how is it that they're able to do that? Well, that's our joint position sense. These joint mechanoreceptors and muscle spindles and Golgi tendon organs all provide the brain with a composite picture of the position of our limbs and the position of our body in space, and that's what we refer to as joint position sense. Now, in the QME exam, our sensory exam consists mostly of testing of the sensory modalities of light touch, of pain, and of two-point discrimination. But we also have the capacity to test for joint position sense. We have the capacity to test for thermal sensation. We have the capacity to test for vibration, but at least to the extent that's required by the AMA guides, we focus first on light touch, also on pain secondarily, and then in certain circumstances we focus on two-point discrimination, specifically and especially as it relates to the upper extremities. The AMA guides do not reference two-point discrimination testing for the lower extremities, but they certainly are clear that two-point discrimination testing is required in the upper extremities, at least for evaluation of carpal tunnel syndrome, and at least for the evaluation of lesion to digital sensory nerves. So with the light touch testing, this is an exam that requires a specific instrument. For this testing we use the Semmes-Weinstein monofilaments. And if you don't have the Semmes-Weinstein monofilaments in your doctor's bag, you need to get those. You need to get those because those are specifically referenced in the AMA guides. And so you want to comply with the requirements of the AMA guides. I think a set of 5 monofilaments is approximately, I think mine were probably $130. I'm kind of guessing, but I remember that they were, sort of expensive, but not prohibitive. And I once had to replace the very smallest monofilament, the 2.83 gauge monofilament. And by the way, if you have the Semmes-Weinstein monofilaments, or even if you don't, I want to caution you to take very good care of those, because especially the smallest monofilaments can get damaged and deformed if they fall carelessly around in your doctor's bag, or if you're just not meticulous in caring for them, the monofilaments can become deformed and dysfunctional, and they are expensive to replace. So You're going to want to take meticulous care of those. For testing pain sensation, of course, we use the Wartenberg pinwheel, the sharp side of the pinwheel. Some doctors use a pin. Some doctors use the open end of a paper clip. And I believe all of those to be acceptable methods. I think I would recommend, however, the Wartenberg pinwheel because it's the most universally used, and also it's reproducible because pinwheels are all made in the same size of pins, and most doctors have these. So I would recommend that you use the Wartenberg pinwheel. For 2-point discrimination, there are many instruments on the market. I especially like the aesthesiometer, the baseline aesthesiometer instrument, and I'm going to spell that for you. It's AESTHESIOMETER, aesthesiometer. And the aesthesiometer has multiple uses. Number one, for 2-point discrimination testing, it's the easiest to handle, it's the easiest to use, and it has the greatest adjustability of the sliding 2-point scale. So I like it for that reason. And then also the aesthesiometer, the baseline aesthesiometer, has a couple of other uses in the QME exam that make it the instrument of choice for not only 2-point discrimination, but just a versatile tool to have in your doctor's bag. And specifically in evaluating digital sensory nerve lesions of the hands, no, excuse me. Well, yes, we do use the we do 2-point discrimination testing for digital sensory nerve loss. But what I meant to say, in terms of an additional use for this instrument, is that when we are examining for impairments of the hand, there are a couple of measurements that involve the thumb. One is radial adduction, and the other is thumb apposition. That require a couple of difficult to obtain measurements, and this aesthesiometer instrument is perfect for being able to do those two measurements. I really don't know how those measurements could be done any other way. So the instrument is perfect for that. And then another use for the aesthesiometer instrument, the baseline aesthesiometer instrument, is in examining for carpal tunnel syndrome. In the ACOM guidelines, now not the AMA guides, but the ACOM guidelines, there's a reference in the ACOM guidelines to an objective measurement for carpal tunnel syndrome, and it's known as the wrist width to thickness ratio. The wrist thickness to wrist width ratio. And you can imagine that if there's congestive edema in the carpal tunnel, that the thickness of the wrist could increase. And so the thickness of the wrist should be no more than 7/10 of the width of the wrist. And these measurements are easily obtained with the aesthesiometer, the baseline aesthesiometer instrument. So there's a couple of excellent reasons why to have the baseline aesthesiometer instrument in your tool bag, in your doctor's tool bag. Okay, so when we do our sensory testing, we're going to use these instruments, and we're going to test the receptors that we've talked about earlier. And in order for our examinee to report to us what it is they feel during the sensory testing, that sensory information has to reach their consciousness for them to be able to respond to your request to identify the location or the sensation that they feel. So let's talk about some of these ascending pathways whereby this sensory information then makes it up into their consciousness so that they are able to respond to you. Now, pathways, the so-called specific pathways, pathways that are specific for touch, for pressure, for vibration, from the lower extremities and trunk up till about the level of C6, ascend in what's known as the fasciculus gracilis. This is part of the dorsal columns. And when we talk about specific pathways, or that the pathways are specific, that refers to the ability of your brain to be able to specifically and accurately localize the exact location of the stimulus. There are other ascending pathways that sensory information ascends up to our cortex and into our consciousness that are the so-called nonspecific pathways. And with nonspecific pathways, we are not as able, as well able to specifically and exactly identify the location. We're aware of the location of a stimulus, but the exact location of that stimulus is harder to localize. So our specific pathways from the lower extremities in a trunk ascend in the fasciculus gracilis. Specific pathways for touch, pressure, vibration, and proprioception from the upper trunk, from the arms, the head, and the neck. They also ascend in the dorsal column in the fasciculus cuneatus. So if you remember pictures of the cross-section of the spinal cord, below the level of about C6, we do not have a fasciculus cuneatus yet. We only have a fasciculus gracilis. But above the level of about T6, we start to see sensory fibers starting to populate the most medial aspect of the dorsal columns, contributing to the ever-thickening fasciculus cuneatus. And in addition to those specific pathways, the non-specific pathways for pain, pressure, temperature, tickle, itch, and poorly localized touch, or so-called crude touch, they are ascending in the anterior and the lateral spinal thalamic tracts. And these are sensations that we may be aware of their presence, but we have difficulty localizing the exact location of the stimulus. Now, in the face, sensory information reaches our consciousness in the primary somatosensory cortex through ascending pathways associated with the trigeminal nerve, the so-called trigeminal thalamic tracts. And the trigeminal thalamic tracts convey sensations associated with touch, pressure, vibration, pain, cold, warmth, itch, tickle. All these so-called cutaneous sensations from the face, the nasal cavity, the oral cavity, and even the teeth ascend through the trigeminal thalamic tract. In other parts of the body, receptors for touch, pressure, vibration in the lower limbs and trunk ascend in the posterior columns in the fasciculus gracilis, and then similarly in the fasciculus cuneatus, the same information from the upper limbs, upper trunk, neck, and some parts of the head ascend in the fasciculus cuneatus. Now recall that these are all first-order neurons making their first synapse in the medulla in both the gracile nucleus and in the cuneate nucleus, from all the way from the periphery, say for example in the hand, all the way from the hand up through the peripheral nerve, eventually into the dorsal nerve, through the dorsal root ganglion and up into the dorsal root, and then ascending in the fasciculus cuneatus these sensory neurons make their very first synapse all the way up in the medulla. So very long neurons with long peripheral processes and long central processes. And then finally, the spinothalamic tracts, they convey axons associated with sensory receptors responsible for giving us our sensations of pain, of cold, of warmth, of pressure, of tickle and itch. And by the way, I don't know if I mentioned it earlier, but tickle and itch are both subsensations of pain. They're both modifications of pain, and that'll probably make sense to you if you think about the last time you had poison oak and you were itching all over. It's because of chemical stimulation of free nerve endings that give us this sensation that we refer to as itch. It's actually a subsensation of pain. But anyway, these spinothalamic tracts, like the sensory neurons that ascend in the fasciculus gracilis and in the fasciculus cuneatus, convey long axons. In this case, these are second-order axons that project then all the way up in various nuclei in the thalamus before finally projecting like sensory neurons in the fasciculus gracilis and fasciculus cuneatus that then project to the primary somatosensory area of the cerebral cortex. Once up in the cerebral cortex, if you remember back in Neuroanatomy 101, there was the sensory homunculus mapped, laid out over the cortex in the area of the postcentral gyrus, immediately posterior to the central sulcus of the cerebral cortex. And if you remember that sensory homunculus, it gave large representation to cutaneous structures associated with the lips, with the face, and then especially also large cutaneous representation, of course, for the hand. And that explains why the hands and parts of the face are so exquisitely sensitive. And that also explains why the hands and the face provide good areas for us in the clinical exam to perform our testing.